Um, so this presentation is really aimed at the residents. When I've been talking with them, it sounded like spina bifida was something that they felt like they could use more education on, and so I figured that would be a good thing to focus on for the Grand Rounds talk. So, I have no disclosures to disclose. In terms of an outline, we're going to start off talking about the spina bifida diagnosis and initial assessment. We'll then talk about, we'll talk about in particular in utero diagnosis, prenatal imaging, clinical findings, timing of repair, which now focuses on in utero versus postnatal repair, aging and effects of aging on spina bifida. We'll talk a little bit about hydrocephalus treatment and also the evolution of treatment over time in these patients, and then where we're going in the future. And then if we have time on the end, we'll also touch base on encephalocele and some other anomalies that it's useful to be aware of. So when we think of spina bifida, there's multiple different spinal cord abnormalities that we can discuss that are sort of beyond the scope of this talk. But when we think about it in sort of broad strokes, we can divide this into three categories. We have spina bifida occulta, which is absence of the spinous process and variable amounts of lamina. There's no exposure of the meninges or the neural tissue, and it may be associated with diastatomyelia, tethered cord, lipoma, dermoids, but unless there's one of these associated conditions, they're typically asymptomatic. We can then think of meningocele, where you have a defect in the vertebral arches with cystic distension of the meninges, and about 1/3 of these patients have a neurologic deficit. And then we have myelomeningocele. This is really what most of us as pediatric neurosurgeons think of when we think of spina bifida. We're not thinking of these less severe patients. We're focused on these myelomeningocele patients. So these patients have a congenital defect of the vertebral arches with cystic dilation of the meninges and structural or functional abnormality of the spinal cord and cauda equina. It is associated with specific cranial findings, which we'll go through in addition to the abnormalities of the spine. And it tends to happen in less than 1 in 1,000 births, but we'll go through later in the talk. This varies widely depending on where you are in the world. So in the United States, this is typically an in utero diagnosis in patients that have good primary care. So a maternal serum alpha fetoprotein is sent between 15 and 20 weeks, usually between 16 and 18 weeks into the pregnancy. And this is elevated because of the failure of the closure of the spine in patients who have spina bifida. Most patients also undergo a second trimester ultrasound, and this looks for anatomical abnormalities throughout the body of the fetus. And so this is another place where spina bifida may be picked up in utero. The incidence of meningocele or myelomeningocele is about 0.1 to 0.2%, but it increases to 2 to 3% if a previous child from that mother had spina bifida, and to 6 to 10% with 2 previous children. And one of the reasons for this may be that if a patient has had a prior pregnancy with spina bifida, they may have difficulty absorbing folate. So for instance, bariatric patients with a history of bariatric surgery, or some patients with other gut abnormalities may have difficulty resorbing folate, and this could be an issue for future pregnancies. Overall, the incidence is decreasing with folate use. It's recommended that all women of childbearing age be on 400 micrograms of folate, and this is really because by the time a woman knows she's pregnant, that this has already happened, and it's too late to start folate and fix this. So it really needs to be before conception. And then women who have had a prior pregnancy with myelomeningocele are actually put on elevated levels of folate beyond this. There's significant geographic differences in the incidence, and this is really due to differences in prenatal care and picking this up in utero, differences in folate consumption in the diet, as well as views on termination. And this, though it has significant morbidity and mortality, and it's estimated that 1-year survival is 88 to 96%. So board aspect, for those of you who are studying for your written boards next year, you want to know that this is a defect in primary neurulation, and this happens around 22 to 23 days into the pregnancy, where you have closure and lack thereof in spina bifida. So when patients are diagnosed, usually it's initially visualized on an ultrasound that the maternal fetal medicine doctors are doing. But then once this is picked up, most of our patients will end up having a fetal MRI. This better assesses the level and also looks for other associated abnormalities. So this is an abdominal MRI of the mom that shows you the fetus. You can see the head here, the spine coming down here, and this is the equivalent of a sagittal image of the fetus. And here you can see the spinal cord coming out the back and this outpouching from the spina bifida. So that's pretty classic. Sometimes you'll see a bigger sac, a smaller sac, but you'll see this opening where it's not just the skin coming straight down. Some of these patients will have hydrocephalus already in utero. This is what would be the equivalent of an axial image of the head with the ventricles here. So this baby did not have significant hydrocephalus in utero, but some it will be very severe. And then here, this is a sagittal image of the head. You can see the eyeball here, and you can see the low-lying cerebellar tonsils, which is the hindbrain herniation that you see, or Chiari-2. So what are the clinical findings of spina bifida? I know some people struggled with this a bit when we were doing the mock oral boards, so we can go through this in detail. So one issue is motor function. This is related to the level at which the myelomeningocele is, but it's not a one-to-one correlation. There can be up to several levels difference between the structural level at which you see the anatomic defect and the functional level at which motor function is missing. And that can either be above or below the level of the myelomeningocele defect. The patient may have anywhere from no motor function in the lower extremities to mild clawing of the toes, depending on the level and how this correlates. It's also important to distinguish reflex movement in the newborn versus true spontaneous movement. So this is a baby who was born at our institution with myelomeningocele, and you can see the feet are in this contracted position. If you pull those toes down, they spring back into that position. But that's not true movement, that's contracture, and it reflexing back into that position. So that's really important to know, because you want to assess, once a baby is born, you want to assess what is their functional level, where does their motor function end. As children become older, they may require bracing, crutches, a walker, or a wheelchair. So depending on how significant the motor deficit is, they may need support for ambulation or be unable to ambulate. And that really is going to be a big aspect that contributes to their disability as they get older. So most of these patients will also have urinary dysfunction. Since this is more in the sacral region, this is almost all of them will have these issues. So they need a urology assessment. Many of them will require straight cathing, and they also need a renal assessment or nephrology assessment because due to the bladder dysfunction, many of them will have secondary kidney issues. And that actually was one of the things that historically has limited lifespan in these patients, is their kidney disease. Hydrocephalus is frequently present as well, but not all patients will have this. Many of them will have the Chiari-2 malformation, and this can cause significant respiratory dysfunction in a subset of these patients, and is another contributor to mortality in patients that have a severe Chiari-2. It can also be associated with a kyphotic deformity or scoliosis. So you can see there are multiple different problems and multiple organ systems at play in these patients. As a result of this, we see children in a combined spina bifida clinic that involves myself, our orthopedic surgeon, our urologist, a social worker, a pediatrician, a nephrologist, a GI doctor because of some of the constipation issues. And so that helps the families with not having to come to quite so many different hospital visits. So this is just to focus on the cranial abnormalities that we see in these patients. So hydrocephalus may be present, but is not always present. The Chiari-2, it's important to note, unlike Chiari-1, where the cerebellum is just low-lying, and that's the Chiari that's just the patient who walks in who has an incident, has a Chiari, but no syndromic or other issues. That Chiari is low-lying cerebellar tonsils. In Chiari 2, it's not just that, it's also the wrapping around of the cerebellum around the brainstem. And so this can cause significant compression on the brainstem and sides of the brainstem, even if it may not look quite as bad when you're looking at your sagittal view. So it's important to evaluate both the axial and the sagittal cuts in these patients. They may also have a medullary kink, and they frequently will have an enlarged massa intermedia. So this is something to be aware of if you're thinking about ETV on these patients. You need to make sure you know and assess the size of the massa intermedia. So what happened historically? Historically, in countries that had resources, after delivery, the patient is taken to the OR for closure of the back. And historically, many times the idea was close the back, put in a shunt, one surgery, both problems are fixed, and now the patient's treated. But the problem with this is that not all patients need shunts. So this was likely leading to shunting more patients than was needed, and then long-term shunt dependence and shunt complications. And so over time, this has really been reevaluated as a strategy, and we'll talk a little bit more about that later in terms of what is the ideal timing and which patients should be shunted and which ones should get ETV. Lifespan in low-resource countries is frequently limited by infection and resources to repair, as well as resources to treat hydrocephalus. Lifespan in high-resource countries tends to be limited by kidney injury if there's urologic issues that are not adequately treated, or in the newborn phase by the Chiari 2 if they have severe respiratory depression from that. So I wanted to take some time to talk about the MOMS trial. We talked about this a little bit in Journal Club earlier this year. Victor presented, but I wanted to focus on this in a bit more detail. So the MOMS trial is really a landmark trial in neurosurgery. In neurosurgery, we have few trials that are truly a randomized controlled trial, and that's what this was. It was published in New England Journal of Medicine in 2011. And what in this trial, 3 centers, CHOP, Vanderbilt, and UCSF, had patients either randomized to prenatal or postnatal closure. And what's also, I think, pretty unique is during the period of the study, all other centers in the country agreed to a moratorium on considering fetal surgery for myelomeningocele. So any patient where this was in consideration was sent to one of these 3 centers, and then randomization was discussed, and they were randomized to prenatal or postnatal repair. It is really important, though, to look at what the inclusion and exclusion criteria were, because they were very specific. And since the release of this trial, some centers are strictly following these criteria, others are trying to expand them. And I think there is some question of how generalizable these results are to an expanded population as opposed to those in the specific criteria. So inclusion criteria for this was a singleton pregnancy, myelomeningocele with an upper boundary between T1 and S1, evidence of hindbrain herniation, gestational age 19 to 25.9 weeks at randomization, normal karyotype, US residency, and maternal age of at least 18 years. I think since that time, there's some thoughts, different centers vary a bit in terms of the age to do this. The younger you do it, the more risk that if they deliver early as a result of the surgery, you have a pre-viable infant. So that's a concern with the younger ages. The older ages, if you get beyond 25.9 weeks, there's a lot of concern that the hindbrain herniation does not reverse. So I think it's evolving more towards getting closer to around that 25-week mark, not super early, but not going much later either. Exclusion criteria are really important too. So a fetal anomaly that was unrelated to myelomeningocele was an exclusion criteria. So hydrocephalus, Chiari 2, those were considered fetal anomalies related to myelomeningocele. They were obviously included, but if the patient had an additional abnormality, for instance, with their kidney or their heart, that was an exclusion criteria. Severe kyphosis was an exclusion criteria. Risk of preterm birth, including short cervix or previous preterm birth and another pregnancy by the mom, was also considered an exclusion criteria. Placental abruption, BMI of 35 or more. So obese patients were not considered in this trial. And if the mom had a contraindication to surgery, those were all excluded. The prenatal group was repaired before 26 weeks of pregnancy and then stayed locally with a support person until C-section, which was planned at 37 weeks, or if they delivered earlier. The postnatal group underwent a C-section at 37 weeks and then postnatal repair by the same team. And this was stopped early after 183 of 200 planned patients, and the report was based on 158 patients. The official reason for stopping early was efficacy, but if you talk to some of those involved in the study, another reason this was stopped early was that this was an extremely costly study to run. And so that was another issue with conducting this study. So what were the outcomes? Fetal death was one of their original outcomes, and there were 2 perinatal deaths in each group. So in the prenatal group, there was a stillbirth at 26 weeks and a neonatal death due to prematurity at 23 weeks. And both of these were post-op day 5. So I think it's fairly safe to assume that these were the result of the fetal intervention. In the postnatal group, 2 patients died due to severe symptoms of Chiari-2. And we think of fetal intervention as helping improve Chiari-2. So 2 deaths in both groups, unfortunately. There were then 2 deaths, 1 in each group between 12 and 30 months. In the prenatal group, this was due to Coxsackie septicemia. In the postnatal group, this was due to a complication of chemo for choroid plexus carcinoma. So I think it's less clear that these are related to the spina bifida. So in the maternal side, there were no maternal deaths, thankfully. But there were a lot of maternal complications. So oligohydramnios, choriamniotic separation, placental abruption, spontaneous membrane rupture, and 1/3 had dehiscence or thinning of the prenatal scar at the time of delivery. So this is pretty significant and severe. That puts them at risk of having abruption. In terms of hydrocephalus, 40% shunt rate in the prenatal group, though 70% met criteria, and 82% shunt rate in the postnatal group, though 90% met criteria. Although we'll discuss a bit more, there is some critique that how we treat hydrocephalus has changed in the period where they were doing the study versus now. They definitely found less hindbrain herniation, but there have been more surgeries for delayed tethering in these patients subsequent to closure. And then premature birth is a significant issue. The average gestational age in the preterm closure group was 34.1 weeks, and 13% were delivered before 30 weeks, while in the postnatal group, the average was 37.3 weeks, and none were delivered before 30 weeks. So you may be gaining some benefit with the additional risk of preterm birth. So this really is something that needs to be worked on. And 1/5 of the prenatal group had respiratory distress when they were born. So in post-hoc analysis, they found that infants in the prenatal group were more likely to have a function 2 or more levels better than that predicted by the level, and less likely to have function 2 or more levels worse than that level. They were also more likely to walk without orthotics or devices. So this is a significant benefit. So what about after moms? How generalizable is this, and what's happened since? There's a Brazilian group that's published their results. They had 237 patients, surgery between 24 and 27 weeks. They had a 24.2% risk of preterm labor, and preterm rupture of membranes was 26.7%, 0.8% placental abruption, 2.5% dehiscence, 71.4% reversal of hindbrain herniation, and about a 2% perinatal mortality, 3 with intrauterine demise, and 2 with neonatal deaths. Additionally, since the time of the MOMS trial now, many more centers are doing this in addition to open repair, which is how the MOMS trial was done. There are some centers looking at fetoscopic repair. There have also been animal trials of cellulose type materials slapping these down on the plaque code rather than truly doing a 3-layer closure. So there's a lot of variability going on around the country and around the world. world currently. So it's also important to think about with these fetal closures, not just the risk to the pregnancy at hand, but also there is risk to future pregnancies for that mom. So if that mom wants additional children after, this is something that needs to be counseled about and addressed. So there's 693 cases in the fetal myelomeningocele registry. And 77 subsequent pregnancies in 60 women. There was a live birth rate of 96.2%. 52 pregnancies were delivered beyond 20 weeks with median gestational age at delivery of 37 weeks. But the uterine rupture rate was 9.6%, resulting in 2 fetal deaths. Spontaneous pregnancy loss at less than 20 weeks was seen in 10 patients, 13%, with median gestational age of pregnancy loss of 10 weeks. Now, early pregnancy loss is quite common overall, so some of this may not have been related, but the rate may be a little bit increased. The median gestational age at the time of uterine rupture was about 28 weeks, and it was seen at 26, 26, 28, 31, and 32 weeks, with 40% of the rupture cases and resulting in fetal death for a fetal death prevalence of 3.8%. So this leads to some consensus recommendations for what should happen with these mothers in future pregnancies if they've had a fetal repair. So it's recommended that they have care at a center with open myelo repair and that they get both pre and post-conception counseling. There's a discussion for recommendation of interdelivery interval of greater than 24 months and providing contraception to prevent any earlier interdelivery interval. Folic acid supplementation is increased to 4 milligrams daily prior to conception, rather than the lower dose that all women are recommended to be on. Prenatal screening is done for myelomeningocele. They're supposed to have frequent provider contact during the pregnancy to assess for symptoms of preterm labor or uterine rupture, and a planned delivery via C-section between 36 and 07 weeks and 37 and 67 weeks, just estimated gestational age. So in the years that have followed the MOMS trial, there are now more centers doing fetal repair. Some centers are using fetoscopic technique. This may have lower rates of prematurity and maternal complications, but it probably has higher rates of retethering in the infants, so it may not be achieving as much benefit in them. I think overall, when you talk to physicians around the country, neurosurgeons are more skeptical about embracing fetal repair than neonatologists and MFM docs are. I chaired a panel, not this year at CNS, but last year. And even amongst those who are performing fetal repair, there's very good discussion of the pros and cons of these repairs. Whereas if you talk to MFMs, they think everyone should have fetal repair. So it's interesting the differences between the fields and how they view this. We are hoping to start a center here too. I'm collaborating with Rodrigo Ruano in the OB-GYN department, as well as Michael Paitis, their chair, on working to establish a program here. I think there are real benefits, but we do need to appropriately counsel families regarding the risks and the pros and cons and not overstate the pros of the surgery. It's still a debate within the neurosurgery field, despite a randomized controlled trial. And so take-home points, I think there may be less hydro, but the exact extent of that benefit is not clear. There's probably slightly better function. There's real complications in the moms and with prematurity, including for future pregnancies. There's more retethering down the line, although there's some discussion of what we can do in our closure techniques to try to minimize that retethering. And then it's not clearly generalizable to those outside of the study population. But it definitely is worth discussing with an educated family. And my children that I take care of who had fetal closure are among my patients that are doing a little bit better than the average spina bifida patient. That being said, those patients mostly came from families with a lot of resources that allowed them to travel to centers where this could be done. So that may also bias the results in those individual cases that we're seeing. So what does postnatal closure involve? And how do we evaluate a patient when we're called? I think this is really important for the residents because you may get a phone call that a myelo baby has been delivered. Often we know that baby is coming and we try to set up delivery with an OR the following day. But if the patient did not have great prenatal care or comes in early, it may be a surprise phone call. So once the baby is delivered, the patient needs to be evaluated. We typically place them on AMP and GENT as prophylactic antibiotics to reduce the risk of meningitis because of the open neural tube defect. We don't want bacteria getting into the CSF space and causing infection. We place a wet TELFA on the open placode. These are 3 images. These are one patient and this is another where you can see the open placode. So we place the wet TELF on it to avoid the placode from drying out. If it dries out, that can lead to worse outcomes. They get a head ultrasound to evaluate for hydrocephalus, and we typically repair on day of life 1 or 2. It's usually day 1, but the studies actually show you have up to 72 hours to repair it, though most of us will do it the next day. We stabilize the child on day 1, day 0, and then operate on day 1. So for myelomeningocele, positioning needs to be started at intubation in terms of thinking about positioning. You can't just place these children flat on their back for anesthesia to intubate. So you need to work with your anesthesiologist. We typically will put a foam donut around this and then place them on their back on that so that there's no pressure on the defect when they're intubating. We then position them prone. This baby did not have a lot of contractures, so pretty easy to position with 2 gel rolls and then the head on a gel donut. But some patients will have contractures at the level of the thighs where the legs come straight down. So sometimes then you need to have layers of blankets followed by gel rolls and get a little bit creative in the positioning. And then you don't want any pressure on the toes or the feet. So what are the steps of closure? This is a 3-layer closure. And so first we identify the placode. In this picture, you can see the placode here. In this picture, you can see the placode here. We have to separate the placode from the surrounding skin. We then roll the placode on itself to close the placode. We then identify the dura. It's not normal dura. It's abnormal dura that's underneath the surface of that skin there. We close the dura, and then we free up skin flaps plus minus muscle and close the skin. So this is a diagram I found online that I thought was helpful. So you can see for this cross section, this would be the placode here. The nerve roots are coming down, and so you need to be very careful as you cut the skin that you don't accidentally cut through nerve roots here. You just want to cut through and separate this skin. Then we roll this placode together and close that with peel sutures. Then this is the underlying abnormal dura here that gets closed next, and then the skin gets brought over. Sometimes there's enough skin that can easily be closed without tension. Other times it's a very large defect and we may need more muscle flaps or even involving our plastic surgery colleagues to help close some of these larger defects. The fetal closure is similar at some centers. So in terms of the fetal closure, there's an abdominal incision through the mother's abdomen. The uterus is then brought out of the abdomen. And then, so basically the base of it is in the abdomen and you bring it out. And then depending on how the baby is positioned, that will determine where the incision is made in the uterus, with the idea of then bringing the baby's back into that uterine opening so that the closure can be attempted. Some centers are doing a 3-layer closure like this. In the prenatal repairs, that increases the length of the surgery, but probably decreases rates of tethering down the line in these babies. Other centers are doing a modified closure that does not fully involve 3 layers, particularly some of the fetoscopic ones. And there's also some centers that either in animals or in humans are working with onlay grafts and things like that. And so it is quite variable. Not all fetal repair is the same. I personally think the 3-layer closure is really going to be the right answer in terms of reducing the retethering rates that are a problem with our prenatal repairs. So what does retethering mean in these patients? So I think it's important to note that if you get an MRI on a patient with spina bifida, post-repair, it is always going to look abnormal. They're going to have a low-lying spinal cord, as you can see here. They're probably going to have posterior displacement of the spinal cord. They may even have a large syrinx in their spinal cord, and all of that may be perfectly normal for them and not an issue whatsoever. So really, understanding retethering in these patients is a clinical diagnosis. We're not operating based on MRI findings. We're operating based on them having clinical symptoms. So you want to ask them about whether they're having any back or leg pain. Are they having a reduction in the distance walked if they were previously ambulatory? So sometimes you might hear, oh, he used to run around all the time and now he doesn't want to run. He doesn't want to go to the playground. He doesn't want to move much. He says his legs hurt. That kind of thing may clue you in that there's a problem with retethering. Turning in of the feet or changes on the orthopedic exam can be another clue, and then changes in bowel or bladder. So a patient who did have some degree of continence now is having worsening issues on their urologic assessment. That's another clue. And these are the same symptoms that you would see for a tethered cord in a non-spina bifida patient. So the same kind of things you're looking for, although they may be harder to assess in a spina bifida patient because baseline, they have some deficits already or some issues which you're trying to assess whether these have worsened or whether they're more stable. The rates of this, as I said, are likely higher with prenatal closure. And then what about general health of these patients? Well, weight gain reduces ambulation. And so there are some patients who will ambulate early in childhood and without retethering will lose ambulation later in childhood or their teen years because of the weight gain and the difficulty getting themselves around when they already have issues with muscle strength. So we really put a focus in our spina bifida clinic with our young patients of talking to the families about trying to avoid excessive weight gain in infancy to avoid issues later on. And you can imagine this is a bit of a spiraling cycle. If you have a patient who's not fully ambulatory and eating, then they're not exercising as much, more weight goes on, then it's harder to move, additional weight goes on. So this is really something we need to stay on top of as physicians. So I mentioned that one critique of moms is that hydrocephalus treatment for myelomeningocele may have changed over time. And so I wanted to look at this because there was this, and this is a paper that we put together a while back in 2019. But there was a perception amongst the pediatric neurosurgery community that less patients are now treated for hydrocephalus than in prior years, that less were treated at the time of their initial repair, and that less were getting shunted and more were getting an ETV. So we wanted to test these hypotheses and see if they were true. We published this paper back in 2019 in a neurosurgical focus that was devoted to spina bifida. And Evan Luther was part of this project, as were a couple of our medical students. David McCarthy was the one who was the first author. And we looked at the nationwide inpatient sample database from 1998 to 2014 for patients with spina bifida and hydrocephalus. We looked at timing of treatment, either simultaneous myelomeningocele repair with hydrocephalus treatment versus delayed treatment at a different time than the closure was done. Overall, this came out to 10,627 inpatient repairs. 77.5% had documented hydrocephalus. 71.4% were treated with a shunt. 4% were treated with an ETB, and 24.6% were untreated for hydrocephalus on their initial inpatient stay. So some of our hypotheses panned out to be correct. So the hydrocephalic patients in the later years were less likely to receive treatment for hydrocephalus during their initial inpatient stay. The inpatient treatment failure rate was higher for ETV, 17.5% versus shunting. Delayed hydrocephalus treatment was more prevalent in the later time period, 77.9% versus 69.5%. But one aspect of our hypothesis, which we were not able to see as true, was that the rate of ETV appeared relatively constant over the period that this was studied. Now, it's possible that this is because our data set ended in 2014. Maybe now we would see more ETV, but it's also possible that this included all closures, including at centers other than major academic centers, major children's hospitals where ETV is commonly used, some of the other centers may be more likely to stick with shunting as opposed to switching over to ETV. So what are our overall take-home points for spina bifida? We need to think about the fact children will have motor and bladder deficits, but the severity varies. They'll have variable ability to ambulate, and the level of need for assistance is variable and may worsen as they age. Many children will need treatment for hydrocephalus, but not all. These kids are good candidates for ETV CPC if they do need treatment, but this tends to work better if they need hydrocephalus treatment in more delayed fashion. So if they don't need if they need hydrocephalus treatment right away with the initial closure, if the ventricles are huge, usually the shunt is the best option. If it's a little bit more delayed, the back is closed, we weren't too concerned about hydrocephalus, but then we start being concerned about the back or leakage, then frequently we will put in a reservoir and tap off fluid until the back heals up. An ETV is not going to change the drainage pattern enough initially in order to allow the back to close if we're having concerns for the back leaking. But if a child doesn't need hydrocephalus treatment early on, or even those kids who get a reservoir, but then we're subsequently able to wean taps, and these children get to be 4, 5, 6 months of age, frequently, if we do ETV CPC, then that will work for them very, very well and avoid a shunt in these patients. We also talked about in utero repair may be beneficial, but is not clear cut. I personally think it probably does reduce shunts a bit, but maybe not as large of a impact as the study suggested based on our changing how we treat these patients and timing of it. It does reduce hindbrain herniation and it improves the level of motor function. But the con is that it leads to increased preterm birth and increased maternal complications, as well as increased retethering. One of the big things with fetal surgery is trying to keep the mom pregnant after the fetal surgery. So a lot of that involves pain control, how the anesthesia colleagues manage the patient, trying to reduce stress on the mom to reduce the risk of her starting contractions and going into preterm labor. And then another point that I wanted to drive home, because I think this becomes very important in adult neurosurgeons who inherit a patient. There's a lot of discussion of transition of care of these patients and who should take care of these older patients. But if a patient has new symptoms attributed to a Chiari-2, you need to check the shunt. And there's an adage in pediatric neurosurgery that it's always the shunt. So a patient who has done well without significant Chiari-2 symptoms and then shows up and is having swallowing dysfunction or other things that you think are attributed to Chiari-2, the most common reason for that is that their shunt is no longer working. So you really need to explore the shunt and make sure that's working. And most of the time that will resolve these symptoms. If you explore the shunt and it's working, then you could think about addressing the Chiari-2, but you never want to go to the Chiari-2 first. Additionally, it's important to note that myelomeningocele patients with shunt malfunction tend to get very sick very fast. That's because of this lack of room in the posterior fossa. And so though all shunt malfunction patients can be a true emergency and get sick very fast, the myelo patients and the slit ventricle patients tend to, amongst those patients, get sick even faster. Reducing weight gain helps reduce functional decline. Monitoring for symptoms of retethering is important, and these patients require multiple specialists working together to optimize their care. So neurosurgery, urology, nephrology, orthopedics, etc. So what are the future directions for spina bifida? So we've talked about open versus fetoscopic repair. There's also some discussion about grafts and stem cells and whether this can help in terms of regeneration or recovery. I think this is more, we're not there yet, but maybe in the future. But this is more high resource countries and individual centers. To really decrease spina bifida overall, and reduce it even happening in the first place, the big gains would be in folate supplementation. So there's differences in folate supplementation between cereals versus corn masa products, even in the United States. So we fortify our cereal in the United States with folate, but certain segments of the population have a less cereal-focused diet and more focused on corn masa products or other types of nutritional sources. And these products are not supplemented with folate in a standardized fashion. So that may be one of the reasons for differences in different subgroups within the United States or different localities. So that's something that can be worked on more locally and in the US. And then there's major differences in folate globally. So there's a lot of global health work going on in neurosurgery right now, trying to work country by country to lobby for folate supplementation to reduce rates of spina bifida. There was a nice paper that came out in Lancet Global Health in 2022 by a number of neurosurgeons who have worked very tirelessly on these efforts. Jeffrey Blount and Gail Rousseau are two of them that have really pushed for this. And they looked at what would happen if you had universal mandatory food fortification with folic acid and tried to make a case for this. So when they looked at some of the countries that don't have folate supplementation, these are some of the largest countries in the world. So if you had folate supplementation and you did that in India, that would affect 553 million people. In China, that would affect 1.2 billion people. And so then how many neural tube defects would that avert? In India, it would be 22,000 neural tube defects. In China, that would be 14,000 neural tube defects. That would impact the number of deaths under the age of 5 that were averted. They estimated 20,000 and 11.6 thousand. And then disability affected life years are multiplied even beyond the number of neural tube defects. So these were reaching huge numbers. And then a huge economic impact from this. So they estimated in India, it would save 5.5 billion, in China, 20.2 billion. So there really is a strong case economically and from a public health standpoint of trying to increase folate supplementation around the world. This is a map that they showed from that paper, and the countries in green have high prevention and high supplementation. So we're in green, Canada, much of South America, Australia. But you can see here, most of Africa, China and India, Russia and Europe do not have much in the way of supplementation. So big gains could be made by increasing supplementation in some of these countries. We have about 15 minutes and I want to leave time for questions, but I just wanted to very briefly mention encephalocele. So, because these are another problem you may get called for. So these have similar principles for post-care delivery where you don't want them to dry out. But the timing of surgery here is variable depending on the size and the skin covering. So you can see here, this was a large encephalocele with not good skin quality. You can transilluminate to look for the contents. This one only had a small amount of brain contents at the base of the encephalocele. Most of it was just fluid filled. We do a 3-layer closure for these as well, identifying brain tissue, freeing up the bone edges and closing the dura and then closing the skin. So this is what it looks like intraoperatively. This is another large encephalocele. This one has much better skin quality, but it was still so large it needed early treatment. But for smaller encephaloceles with decent quality skin, we frequently will not repair them at birth. We'll wait until the child gets older to repair these. This is just prepping in the OR. You can imagine it's hard to prep around the base, so you can clean and put a stitch in and hold it up to prep. And then this is by keeping some of that fluid, it helps you to dissect out around the skin with an easier plane. So these are some other photos. And then lastly, I just wanted to touch on when you're called to see an infant, it's really important to assess the back. Even if you're called for a cranial consult, you can sometimes pick up other abnormalities in the child. So I think it's pretty obvious that this is of concern. This had a dermal sinus tract extending down and leading to tethering. This was a meningioma that had a dermal sinus tract, but even just a sacral dimple may be a sign that you might have a tethered cord. Hairy patches associated with diastatomyelia. So you really want to assess the back in all of these children as well. So with that, I'll end so we have time for questions. Any questions?
Okay. You're ready to go.
Awesome. Thanks so much for giving me this opportunity to catch up on vascular neurosurgery, interventional neuroradiology, and we'll, sort of near the start of the year. So we'll go through some case presentations and some of the research that we're working on in some of the trials. So, my funding disclosures, I guess, one way is to think about it is I'm sort of equally conflicted. I mean, we test devices for pretty much all the companies in the lab on sort of a regular basis. And that money that we use from testing goes back to support our research. So for the new residents, I'm always really interested to hear how you got to where you are and, follow you as you progress in your training plan, where you go, all your accomplishments, things like that. And I think, when I think about my training, certainly it was painful, but it was also, one of the most fun times of my life. And, I think a lot of that pain is in some ways is how we learn. So, just thinking back to where I started, which was a million miles from here, when I went to college, I thought, maybe college would look a little bit more like this. And maybe in reality, it looked a little bit more like this. And my medical school advisor, actually, when I went back my junior year, she said, back again like a bad coin. I already told you wouldn't get into medical school. And I went down a different path for a number of years. I was a rock climber, and I used to work for the helicopter search and rescue team in Yosemite for 4 or 5 months of the year. And then I would climb around the world for the rest of the year. So a day could look something like this. This is climbing. This is a 7,000-foot ice climb at about 19,000 feet in Peru, versus something like this. This is climbing in Vietnam. And at that point, I didn't realize it, but, we, I think as residents, you're going to have a significant impact every day. It's just at the time, my impact was really secular. And I think in a lot of ways, climbing is fairly selfish. And at that point, I was having a lot of accidents. So maybe the impact that I was having was not really the one that I wanted. So I went back to school, did my residency at University of Virginia. At some point on the way, they had a kid, did 3 fellowships at and a year of endovascular at Jefferson, then went back and did another year at University of Virginia, did a year of vascular and skull base in Auckland, New Zealand. And this year really had a profound effect on me because we had so many new devices. We did one of the first web cases in the world, and this was now, I don't know, 12 something years ago. But all these devices, we were finally getting into the United States 5 to 7 or more years later. I mean, Phil, we just got in the last, I don't know, 2 years, and that was something that we had in New Zealand. This was Surpass, detachable stent retrievers. This Fred device took years to get to the United States. And I think after finishing my training, my son maybe looking around for a little patch of sand, and ultimately end up taking a job at University of Miami. And a large part of that was this infrastructure for research. So this is the lab. We have biplane angiography, MRI, CT, ultrasound. And it's certainly, my friends would tell you that I became a tool at some point in my training. But I think with a lot of these things, you want to have the right tool to the right situation. So you want to be trained to be prepared for everything. Because if you just have a hammer, everything looks like a nail, even if it's a rabbit. And sometimes when you put those two things together, you end up with a lot of nails in the head. So this is a patient that was hearing voices. He shot himself with a nail gun 29 times, and those voices actually went away. And I think part of that, long, painful training, thinking about doing 3 fellowships and all these different things was, I really didn't know where I was going to end up. I really didn't know who my partners were going to be. You don't know in your job who you're going to be surrounded with. This is the team. And, thankfully, we're lucky to recruit Adib recently as well. And on top of that, it's you don't know what setting you're going to be in. I mean, I'm lucky to have great fellows, great residents, and as well to be able to build a great research team. I guess this needs to be updated a little bit, but we have a clinical research team that runs trials, as well as a laboratory research team that does basic science, translational research, and testing. And then on top of that, you don't know where you're going to end up and who your mentors are going to be. And I've tried to keep my mentors, throughout. So these are some of my original mentors going all the way through towards more recent mentors, and probably still needs to be updated because on a regular basis, I'm trying to collaborate with more people. So one thing that I heard in my training on a constant basis is pounded into your head was we do it the same way every time. And I think it's important to do it that way when you're learning in the beginning, because it reinforces what you're learning, and you'll take that away and you'll gain proficiency. But the reality is we don't really ever do things the same time. We think about aneurysms, we can treat them with clipping, we can treat them with coiling, but then even between that, there's 1,000 different iterations. So I think generally speaking, when I think of Mr. T, he said rules are for fools. But I do think that, rules can give us some guidance with how to deal with certain situations. And I figured, maybe we'll just go through some basic cases and then talk about, studies that we have ongoing and try and come away with some rules for some of these cases. And so I think going through some cases, we do see some pretty unique things here at University of Miami. So, I think when you're finished here, you'll be fairly well trained, and some things that you might not see again, or you may only see once a year. Things like this. This actually was a case in New Zealand of a person that made a homemade rocket launcher. And when he set it off, the end of the rocket launcher was right in his face. So some case presentations. So first case, a 68-year-old presents with acute onset of aphasia, right side of facial droop, right side of weakness. He's totally out in the upper extremity and lower extremity. So the first thing is these patients, if they come in by EMS, we actually get a stroke alert. They skip the ER and they go straight for a CT scan. And, I think what everybody's probably thinking here is an acute stroke from occlusion of a large cerebral vessel. So just like the one that we were just doing. So they go straight to the CT scan, they get a CT. While that's going on, they get large bore IVs placed. If the CT is negative, they get TPA in the scanner. And here on the lower cuts of the CT, you can see this hyperdense MCA sign, which not all patients have that, but a large number of them have that, and that would signify a large vessel occlusion. So patient gets TPA in the CT scanner and then gets a CTA on the table. Here you can see this left MCA is out. It corresponds to that hyperdense sign. And then the patient's going to come right up to the angio suite. And I'd say about 95% of our patients are not transferred from another institution. So they come in straight from EMS. And so that's why we have very little time from when the patient hits the ER to when they get to the angio suite. And when I was in my fellowship, on average, they'd call us about a stroke. And a lot of times, we'd go back to eating dinner or whatever we were doing, knowing that it was going to take 3 hours before they were in the angio suite. And that was really when we were just starting to do these cases. So someone like this, they'll come straight up to the angio suite. Here you see there are 3 M2s here, and this middle M2 is out. And you can see this area on the lateral and the insula where they've got a large perfusion deficit. So this is sort of, one schematic of a thrombectomy. Here you can see we bring up a guide first, and there's lots of different options for a guide. Here you can see us crossing the clot, in this case, using a microcatheter to then cross the clot, and then deploying a stent retriever. So this is one of, many, 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 many options now that we can use to remove this clot. In this case, that was a balloon guide that was being inflated into the neck to arrest flow, and then we take the clot out. But the reality is there's so many different ways to take these clots out. This is one of the first stent retrievers, the Solitaire, and at the time in New Zealand, we were actually using this to coil aneurysms. This was a detachable stent. And during one of those cases, someone noticed clot forming while we were stent coiling an aneurysm. And ultimately, they pulled that stent out and it removed the clot. And that's what led to the idea of thrombectomy in a lot of ways. And so even though this device was made for aneurysms, it actually works really well for thrombectomy. And those were the cases that we were doing then. So you can see here, this case, we go up, this is in that M2, we pull out that clot, and at the time we were doing these cases awake. And so this was the patient on the table, we would sit him up. And I think that's one thing that's still, waiting to be answered. So this was a patient, aphasic, not moving his right side. And you can see on the table now he's able to smile and he's got symmetric weakness and he starts talking. So one of the trials we've been trying to launch for quite some time is whether we should be using anesthesia or no anesthesia for these cases. And that's still an unresolved question. At the moment, we tend to use anesthesia for most, if not all, the cases, but there are some pluses and minuses, and that's an area that needs to be still sorted. We had initially gained favorable results with a 50-center randomized clinical trial that looked like the NIH was going to support it, but a lot of different sort of arguments or just counter views on how we should do the trial and this and that have kind of led to being stalled. And since that time, we've had a couple small randomized clinical trials at other centers, but still, I think whether you should be using anesthesia for a stroke remains to be clarified. And since, we started these cases, we progressed a long way. This was one of the fastest strokes that we have done still to this day. This was a patient that was undergoing a cardiac cath actually at the VA hospital. They noticed afterwards he wasn't waking up. They went back in. The cardiologist did an angiogram showing a basilar occlusion. He tried with multiple balloons and like cardiac devices to take this clot out and was actually unable to take the clot out. Transferred here, and from groin to reperfusion was 5 minutes and 40 seconds, or from being in the room and prep to reperfusion was 5 minutes and 40 seconds. And this was one of the first cases that I did here using can't even remember if this was the ACE 60. I can't even remember. We've now been through like 7 more generations of catheters. So this was right around when we were starting to use other catheters other than just stent retrievers. And we went on to join the COMPASS trial, which was a large randomized clinical trial showing that aspiration could achieve similar revascularization rates as stent retrievers. And flash forward, we're now seeing much more complicated cases, cases that we wouldn't have necessarily considered doing, 10 or more years ago, cases like this, which is actually the case that we were just doing. This is a case that presented with a 99% internal carotid artery occlusion. And you can see here, they also have this MCA occlusion. So in this case, we did angioplasty just so we could get our thrombectomy system up because we couldn't pass that stenosis with our system. We go up using a balloon guide in the neck with flow arrest. Then we took out this MCA clot. And then on the way out, we angioplasty this further. This is the patient on the table. This was actually one of the last patients enrolled in the DAWN trial. So, now we're moving towards much more complicated cases, and we were one of the highest enrollers in the DAWN trial. This was actually the last patient enrolled in the DAWN trial. And that extended our window from 6 to even 24 hours based on perfusion imaging. So I think that case is clearly a good case for a balloon guide with such a massive clot in the neck, but that's still another thing that hasn't been clarified. Should we be using a balloon guide versus a support catheter for these thrombectomy cases? And currently, we're using balloon guides on the even days and standard support catheter on the odd days, and looking at that as a retrospectively. But there's a lot of evidence that shows balloon guides are better. You can see here recanalization rate 89% versus 68%, single pass 64% versus 36%. And the difference, though, is the time. And this is because originally our balloon guides were pretty crappy. Now we have much better, more trackable balloon guides. But there's a lot of positives to using balloon guide, a lot of negatives. And so we still don't know which is better. And we've tried to get funding for randomized clinical trial. I think at the time I raised about $2 million of the $4 million that we needed for this trial. And ultimately, the different industry partners were arguing over which catheters and which balloons we can use, and it hasn't been launched. So we're still working on this. But that's why currently we're using a balloon guide on the even days and a non-balloon guide on the odd days. Other trials actually these aren't upcoming, these have started. One is Thunder, which is a new pump to remove these clots. And another one is the Imperative Zoom trial, which is using a much bigger, more slinky aspiration catheter to remove these clots. So there's still hundreds and hundreds of things that we haven't worked out in terms of what's better. And because stroke is the leading cause of disability in the United States and one of the major health expenditures, there's now tremendous financial boom in the endovascular world to develop better systems. So even this catheter system, they raised hundreds of millions of dollars just for this catheter system. And this spun off into an entirely separate company in itself. So it's really impressive, you know, how much money has been fueled into this to try and make these cases better. You know, still, even when we open the vessel, a large number of patients will still go on to have significant disability and not improve. So we've got to be able to do these cases better. And this led to one of the recent PCORI grants that we got. We're one of, I think it's 12 centers looking at doing thrombectomy in patients with some level of disability at baseline, because we know that these patients, you know, if they have problems walking or minor disability, somewhere where you're talking about an MRS of 3 to 4, so minor to moderate disability, if they present with a large vessel occlusion and you don't take that clot out, they're all severely disabled or they die. So now we're looking thrombectomy even in these patients with pre-existing deficits. And 2 recent randomized clinical trials have shown benefit in patients even with large strokes already. Sorry, we're just finished this. So this PCORI grant, this is actually a $10 million grant that we were recently awarded to look at stroke in patients with minor disability. So, you know, I think another thing to think about is stroke. You know, how do we cut up the pie? What are the different pieces? Cerebral thrombosis is, you know, about 60%. Cerebral embolism is another 25%. You can see here intracranial hemorrhage, depending on where you are, hemorrhagic stroke is about 15%. So, you know, when you talk about aneurysms and things like that, down here, subarachnoid hemorrhage, it's a much smaller amount. So this is a huge portion of what amounts to stroke. So next case, you've got a 60-year-old presents acute aphasia, right side of facial droop, right side of weakness. So pretty much the same presentation as the last case, but maybe a less acute course. Maybe it's got 3 days of that, but it was acute onset. Patient gets an MRI, you see that they've got multiple emboli, and they've got some imaging here that shows severe stenosis of the internal carotid artery in the neck. And so the question is, you know, does that need to be treated? Certainly, regardless, it needs maximal medical therapy. And then the question is, does it need some other treatment in terms of an endarterectomy or stenting? And this is where we've had so many trials over the years. This is the New England Journal of Medicine CREST study, which showed that for symptomatic stenosis, CEA is similar for stenting in terms of the composite outcome of MI, troponin leak, disabling stroke, and death. The difference is when you do an endarterectomy, you have about a 1.1% chance of having a disabled stroke versus 2.3% disabling stroke for a stent. And then on top of that, death was much less common in the endarterectomy group versus the stenting group. The difference in the composite outcome is because you had a higher chance of a troponin leak or an MI in the stenting group. And me personally, I'd much rather have a troponin leak than a disabling stroke. So I think this is a problem with how they did the composite outcome. So if all things were considered equal, which they never are, I would rather have an endarterectomy. And so that's what this patient got. You can see here, this is removing this dense plaque. But that's not the case for all patients. You know, this is a patient that maybe has bilateral stenosis or radiation or stenosis in the neck and stenosis in the brain, or is on, you know, dual antiplatelets or other factors like that, severe medical comorbidities precluding anesthesia for an endarterectomy. So in this patient, maybe a stent is better. And we're currently enrolling for CREST-2, which is also trying to answer the question of asymptomatic stenosis. You know, should we be treating patients that present with asymptomatic stenosis with stenting or endarterectomy? Other studies we have ongoing are looking at better catheters to do these cases. You know, do we do them radially? Do we do them with a balloon? Do we do them with a more trackable catheter? This is a publication by Luther and Ramsey and the rest of the team looking at endarterectomy versus stenting versus TCAR. TCAR is direct access to the carotid in the neck and provides a filtration system to make sure that you don't get any clot into the brain. And this was really relevant a number of years ago, before we had better radial systems when we would fail sometimes versus from a femoral approach. But I think the question now is, now that we have better radial systems and catheters and better balloon guides, is TCAR really necessary? And I think for rare cases, it's probably a good thing to have, but it's becoming much, much less relevant. And we'll need better data with current systems, new balloon guides, radial approaches. How does that stack up to TCAR? So some other things, problems that we see in the neck. This was a case my co-chief was doing in the other room when I was a chief resident. And this was supposed to be a petrous apex granuloma. This is, just to show you the anatomy, this is the sella. And this is working lateral to where the carotid artery should be, removing a petrous apex granuloma through an endoscopic approach through the nose. And so they were doing this approach next door. And you can see this actually wasn't a petrous apex granuloma. It was a partially thrombosed aneurysm. So they called me in the room next door. And I usually ask, what is the first thing that you do when you get into the carotid in one of these cases? So aside from changing your pants, the first thing that you should do is anytime you're doing a transsphenoidal, have a big Foley catheter ready. So as soon as this happened, put a Foley catheter into the nose, the largest one you can find, with packing, and inflate it. And that will usually tamponade this bleeding so you can get them down to the angio suite. My record was 3 carotid blowouts in one day. That occurred on one Christmas day. And that's when I thought, maybe I should be going into spine or something else. But we do have some better systems for this. We tried a lot of different approaches. Sometimes these patients require a carotid occlusion and a bypass. Sometimes you can just occlude the carotid. Sometimes we use flow diverting stents. And now we have some better stents. So this was a traumatic pseudoaneurysm you can see here with an avulsion of the ophthalmic as well. And this vessel is 5.5 millimeters. So even a couple of years ago, we didn't have even a stent that could track and go all the way up here. I mean, we did in New Zealand, that was a covered stent with bovine pericardium, but unfortunately we don't have that in the United States. And this is the papyrus stent, which is a fairly new stent. It's made for coronary artery perforations. It expands to 5.6 millimeters. It's trackable, and it's 75% thinner than some of the other covered stents that we have. So it has a number of advantages. It does require an IRB, which we started, and we've now done, I think, 10 cases. So I think that's the largest series in the country. And here it's a balloon mounted stent, and it's covered. So it'll immediately stop holes in the carotid. So you can see here, the ophthalmic's gone, the aneurysm's gone immediately on inflation. So another case, 25-year-old, difficulty swallowing, was noted to have a progressive neck tumor. This was actually in New Zealand, and they biopsied this. And that's because on the CT of the neck with contrast, they didn't look at the delayed contrast run. So this is a pseudoaneurysm in the neck, but the hole is fairly small, and there's a lot of clot in this, so it's somewhat stagnant. So if they looked at the dry CT 10 minutes later, they would have seen delayed contrast entering this, and they wouldn't have biopsied this. But this was another case, actually, I was operating in the other room that they called me about, when they biopsied this, quote, tumor, and hit this giant, I think this was a 12-inch pseudoaneurysm in the neck. So this, we have different covered stents. In New Zealand, we had the Aneograft, which unfortunately we still don't have in the United States, but we have other ones that are lined by bovine pericardium or Gore-Tex. And you can see here, this is before and immediately after the stenting. And the benefit of these stents is you can cut down on top of them. So this was actually an ENT case where they asked us to put in the stent beforehand for an erosive tumor, and they actually cut down onto the stent to remove this giant neck tumor. And we've done that for carotid body tumors as well. This is actually looking down into that after removing the tumor and seeing the stent in the carotid artery. So next case, same presentation, 60-year-old, acute onset of aphasia, right side of weakness, but the CT scan shows this giant or quite large left basal ganglia hemorrhage. So the first thing is you want to rule out other sources of this hemorrhage. This could be an AVM, it could be, there's even subarachnoid blood, so it could even be an aneurysm, things like that. So again, we get a CTA, that's negative. And then we're thinking about what to do with this patient. Generally speaking, this is an area that's ripe for research because patients with large intracerebral hemorrhage do terribly. It's one of the things that we still have not made much progress on. Almost 80% disability. Early mortality is about 35 to 50%. Delayed mortality is very significant. So this is a major problem. And this is where, we tried with multiple randomized clinical trials doing a hemicraniectomy or a craniotomy with evacuation of hemorrhage. And it wasn't beneficial in most of the trials, like Stitch 1, Stitch 2, on and on. MISTY was a minimally invasive trial where we put a catheter in, infused TPA, and that was starting to show benefit for these patients. This is the brain path system. You can see here, it looks like a speculum, as Dr. Hiros loves to call it. We can use, an MRI or a CT stealth to go in and plan these cases out. We can now use that with tractography to plan these cases and remove these hemorrhages in a minimally invasive fashion. And I think that the nice thing there is that you just remove the speculum, the inner obturator, and most of this hemorrhage comes out just due to pressure. So for these cases, we do not want to give mannitol because we want to just remove the obturator, and most of that blood will just come out. And that way we don't have to touch the lining of the brain around the ICH, which causes a lot of secondary damage. So you can see here in this case, we actually did a mini eyebrow orbitozygomatic craniotomy. At the end of the case, we can use a little bit of cranioplasty cement to smooth this over, but we can enter this area down the long axis of the clot in a minimally invasive fashion. And this is what it looks like. When I first saw these cases, and I would see a giant vein like this, and we would open the sulcus next to the vein. So we use a transsulcal approach. I thought for sure we would rupture this vein. But here you can see we're going to open the sulcus right next to this vein, fully open that up so that the speculum or the obturator is going to go right down this sulcus. And here, you'd say, oh, this vein, we're definitely going to rupture this vein. But if you go slowly and you open up the sulcus, you can take out the obturator. You can see here, removing the clot. That's looking down into the ventricle. And there's the vein at the end of the case, looking down into the ventricle. So we can go in, remove these clots. This is the imaging afterwards, and take out very large clots like this. And this is, just a little eyebrow incision with this craniotomy. So the ENRICH trial was a randomized clinical trial. Looking at this, it was actually halted early. And it's the first major randomized clinical trial for ICH patients showing a benefit. Primarily showing a benefit for lobar. This is a breakdown of lobar and basal ganglia bleeds. Overall, there was benefit across all cohorts, but when we break it down, it's really the lobar group, and that's why the trial had to be stopped early. So we're going to need, I think about the thrombectomy trials. We did 5 negative randomized clinical trials for thrombectomy before we started doing positive trials, then 6 positive trials. So it was the 5 negative trials for thrombectomy that help us plan the next 6 positive thrombectomy trials. And I think that's where we are with intracerebral hemorrhage as well. We know that minimally invasive removal of hemorrhage is beneficial. It took us a while to come up with a trial to show that. This is actually going to be published in New England Journal fairly shortly. But what you can see here is that the MRS outcomes were better across, discharge, 30-day, 90-day, 180 days with minimally invasive evacuation of hemorrhage. You can see here there's a 50% reduction in mortality, but we still have a long ways to go. And that's partly because it took us a long time in these patients, in some of them, more than 24, 48 hours to evacuate these hemorrhages. Versus something like a thrombectomy. Now we're trying to do it as fast as possible, even often within, 1 hour. We also have a trial. This is in correlation with our neurologists and our neurocritical care doctors. We just submitted this grant looking at tractography with ICH evacuation. So this patient, following this, improves, but not perfectly back to baseline. So let's say that they have right upper extremity weakness, 2 out of 5, that's chronic. So now we do have some things that we can do for this patient as well. DeLeap has a intraarterial stem cell trial going, and in early phase 2 studies published in Lancet Neurology, that's shown some benefit. We also now have, this was a recent randomized clinical trial for a vagal nerve stimulator to improve outcomes with patients with weakness following a stroke. So this was a randomized clinical trial showing that this VNS implant for carotid stimulation actually leads to benefit for chronic mild to moderate weakness of the upper extremity. And this is fairly mind-blowing stuff. This is paired with rehab to improve patient outcomes. And some of these patients had strokes 6 months to 20 years later. So even 20 years later, in some of these patients, there was a benefit of putting in a vagal nerve stimulator for chronic weakness, where, someone that really couldn't use function of their hands, but had some weakness of the arm, gained improvement. And one of these patients was a prior NFL quarterback who could no longer throw a football, who now can throw a football again. So that's really remarkable. Now we're moving towards even remote implantation of these vagal nerve stimulators into the veins and the sinus. And one of those trials was just recently started. And now that company was actually started by one of my friends when he was doing his work before he became a resident. So that was Thomas Oxley. That company just went on to become public. They've raised, I think, over $1 billion at this point to start looking at implantation of stents in the veins in the brain to improve patients with this type of disability. So this is going to happen within our lifetime. Next case. This is a 93-year-old presents with right-sided weakness. They've got coronary artery disease on aspirin, heart valve replacement on anticoagulation, COPD, hypertension, hyperlipidemia, diabetes. You can see here this large acute on sort of subacute to chronic. I guess it's more subacute to chronic subdural hemorrhage. And this is his preoperative versus his 3-month post-operative CT head with middle meningeal embolization alone. So this is a poor patient for burr holes. And so this patient was taken for middle meningeal embolization. And this is the post-op CT at 3 months without burr holes. This is another patient that refused surgery. They're a 40-year-old, 4 out of 5 weakness. And they've got this large chronic subdural, refused surgery. We'd end up doing middle meningeal embolization. This is the CT scan at 3 months. So we know, again, this is another thing that we've opened for patients with predominantly subacute and chronic subdurals is middle meningeal embolization, which knocks out the blood supply that supplies these membranes and can often lead to resolution. The question is, what's our complication rate? We know that it's extremely, extremely low, but it's not zero. And the other question is exactly which subdural patients should we do this in? What's the timing of this? And also, which embolic agents should we be using? Initially, we started out using particles, then onyx. Now we've been using more NBCA, but we also have fill, squid. So for some of these patients, we're also coiling them. And then the other question is, should they be getting surgery and then embolization, or just embolization alone? And all of that is being answered by randomized clinical trials. So we have 2 ongoing now. We have the Onyx trial and we have the GLUE trial for middle meningeal embolization. Both of those are funded. Sponsored trials that are national randomized clinical trials trying to decide which patients we should be doing this. Both of those randomized clinical trials have 2 arms. One for surgery alone versus surgery and middle meningeal embolization. And the other is middle meningeal embolization alone versus maximal medical therapy. Now, aside from that, these are both approximately 300 patient randomized clinical trials, but we need a much larger study after this to really define, based on patient and disease characteristics and optimal agents, how we should be treating these patients. And this is where we have been working on this CHESS, chronic subdermal hematoma treatment versus embolization versus surgery study. This was recently funded by the NIH. This is going to probably be about 50 centers, and we're still working out the budgets and a lot of other elements for middle meningeal embolization, but at least this has been NIH approved, and it's going to follow some of these initial industry-sponsored studies. Next case, this is a 35-year-old, presents with headache, left-sided weakness, goes straight to the CT scanner, has this funny-looking CT for a 35-year-old. It gets a CTA, which shows some funny vessels, and here it gets an angiogram. And some people might think, that looks like an AVM. This is actually a dural arteriovenous fistula with enlarged varices that drains cortically. So dural arteriovenous fistulas is a direct connection between the artery and the vein and occurs within the dura. That's where the connection is. And the key to understanding these cases is where is that abnormal connection? So this is a common case that we get from smaller hospitals, a patient with a dural arteriovenous fistula that was treated with embolization. And what you can see here is they've embolized the occipital, they've embolized the middle meningeal, they've embolized the posterior auricular artery, but there is no glue in the vein. There should be glue within the vein. This is this old embolic material, but they got no glue into these dilated cortical veins. And so this patient presented with a new bleed, progressive edema, and seizures, and then they transferred to our institution. And these can be then really challenging cases because you might not have a good access endovascularly for this. This case, we put up this balloon and we injected Onyx through these other collaterals and we were able to close this. But these cases, and you can see here, this is now glue within the varix and into the vein. So you know that this case is dead. So with these cases, the key is defining where is the fistulous point. And when you get an MRA on some of these patients, every vessel in the brain can light up. So the key is knowing exactly where the fistulous point is. So this is a different patient. Again, thousands of cortical veins lighting up, actually has a secondary Chiari from high pressure in the brain. This patient's fistula is adjacent to the superior sagittal sinus. You can see it here. It's filling from every vessel, bilateral ICAs, bilateral ECAs, bilateral vertebral arteries. But the fistulous point is a pouch just next to the superior sagittal sinus. We did a transarterial approach into the venous system, went into the vein and coiled backwards, starting in the vein all the way into the artery. This fistula is dead. And actually, this person's Chiari also resolved just with fixing the fistula. So fistulas can be classified briefly into low risk. They drain into a massive vein in the correct direction. Moderate risk, they drain into a vein, but in retrograde fashion, or very high risk, where they drain into a cortical vein in the wrong direction and or into the spinal cord and or they have a varix. So whether they need to be treated is based on these types of things. Some of these we just opt to follow, especially the grade 1 fistulas. If they're high risk, like a grade 3, they certainly need to be treated in most patients. And the options are microsurgery, embolization, which can be transarterial, transvenous, or direct approaches, or focused radiation like Gamma Knife or Linac. We have both of those machines at UMH. And then we also can do fractionated radiosurgery at Jackson. So this patient, in a young patient, they got surgery. This is a fairly easy surgery where you come down subfrontal, divide the vein just as it enters the dura. We've done these in minimally invasive fashions. This is a similar case, dural anterior cranial fascia, ethmoidal fistula, draining into a chordal vein. We just put in an endoscope via eyebrow incision and divided this. But what about the same case presenting an 80-year-old? So for this anterior cranial fossa ethmoidal fistula, I think surgery is the best option. You know, although it's more invasive, it has the highest chance of killing the fistula with a lower complication rate. The disadvantage is that it is more invasive. Sorry, give me 1 second. So the disadvantage is a craniotomy is more invasive. What about an 80-year-old presents with headache, left-sided weakness? He's got all these past medical problems. I mean, this is a poor patient for a craniotomy. So in this patient, they've got this anterior cranial fossa. It drains into the superior sagittal sinus. So we can go via a transvenous approach. The key here is you've got to get all the way to the fistula. You've got to have arterial control. You've got to get your glue or your coils into the fistula's point. Otherwise, you're going to have a hemorrhage. And you can see here, this is the microcatheter in the fistula's point, and we occlude this fistula. Same case, but in this case, it's filling from the ophthalmic artery into a cortical vein. So these cortical veins, we can't access that through a transvenous approach. Same sick patient. For this patient, we went through a transarterial approach, out the ophthalmic artery, past the central retinal artery, into the fistula's point, small amount of glue, closes this fistula, and you can see here, this is past the fistula after we've closed it. You can see the central retinal artery still filling, choroidal blush still filling, but that's a potential complication from this type of approach. which would be blindness. And I have reviewed litigation cases where people did this and blinded the patient. And I think if you have a safer and better option, that's what you need to be doing. Unfortunately, if you don't have surgery at your institution, some people can kind of get pushed into doing a more risky approach. 30-year-old presents with progressive headaches. Sorry, I cut out this case. So next case, 93-year-old presents with eye pain, decreased visual acuity, progressive ophthalmoplegia, proptosis, high output cardiac failure from this high flow CC fistula. You can see when we look in their eyes, they've got these dilated vessels. This is the angiogram reconstruction, which is very important for us trying to plan out these cases. This is one of the first cases I did as an attending here. We tried via transarterial approach. You can see there's only a pinhole opening in the carotid artery. So this was probably a 1-2 millimeter cavernous aneurysm that ruptured, causing this carotid cavernous fistula. And this 93-year-old was completely independent at baseline. You know, she lives down the street from her family. The family says she comes to the house every day, takes care of the grandchildren, cooks, cleans. And so she's vital to this household. And I think if this was my grandma, I would do anything to kind of stop this fistula so she could come home and take care of my kids and help me out on a daily basis. And, you know, in someone with high output cardiac failure, they're going to do poorly. On top of this, this has cortical drainage. So this patient's at high risk for having an intracranial hemorrhage as well. And you can see that's because there's severe stenosis of the outflow ophthalmic vein, which is probably going to occlude soon. So you can see here, we try via a transarterial approach. You can see here the problem is that you come up the carotid, you need to take a 160-degree turn backwards, go through this pinhole, and then navigate around to have enough support to get a microcatheter. So I was able to get a wire through this pinhole, but I could not track a microcatheter. So ultimately, after further discussions with the family, I did a direct puncture of the cavernous sinus through this, under the orbit, through the superior orbital vein, occluded this, and caused complete resolution of this lady's symptoms. She went back to taking care of the family. I actually had to present this case on my oral boards, and they were hammering me as to why I didn't leave this patient alone. And the actual time course of this was, you know, I failed transarterial approach. I failed the transvenous approach. The patient was having ST changes with troponin elevation. We stopped the case. I talked to the family again. I said, you know, this is going to require a transorbital puncture. It's very high risk. She's already had what looks like an MI. I think we should send her to rehab, see how she's doing. Maybe the vein occludes on its own. She came back in worse cardiac failure, and that's when we went ahead and did the direct orbital puncture. I have pictures. This lady still brings me a bottle of wine every year. I think she's like 90, I don't know. I guess she's over 100 now. One of the other important things to think about is where the coils are going to go if you're doing one of these cases. So this was a spine case that was done by a different spine attending. And this is an epidural fistula that was coiled by another neurointerventionalist, causing impingement on the thecal sac. So after they coiled this, they also didn't occlude this epidural fistula. They transferred this patient due to increasing compression. So this patient woke up with embolization with an uncured fistula with a huge coil mass pushing on the thoracic spinal cord with new weakness. They presented with only pain. So we took this patient to the OR. This is one of the last cases I did as a chief resident. We did a 2-level corpectomy, and I think we did like a fusion 2 above and 2 below and 3 above. Took out this entire coil mass. You can hear this is the nerve root floating in the breeze around our corpectomy. So we did, I think, 3 above, 2 below, remove this fistula, remove this whole coil mass. And actually, this patient went on to make a great improvement. But I was pretty upset about this case because this was transferred to another institution. They got to our institution, I think, at 1 in the morning. We started this case maybe around 2:30 in the morning. You know, I think now that I've gotten to the University of Miami, it's kind of nice. You know, I don't usually do these cases except for the intradural part. You know, Dr. Levy doesn't want me putting in these constructs anymore. So that's kind of nice. It's been a while since I've done at least pedicle screws and things like that. But depending on which institution you go to, when I was at UVA, the vascular attending would do this entire case, put in the instrumentation and do the fistula. When I went to Jefferson, the spine people did the instrumentation. The vascular part was done by the vascular neurosurgeon. Next case, 21-year-old presents with significant headache, visual deficit, left side and weakness, has this intracerebral hemorrhage, gets an angiogram showing an AVM. So an AVM is a direct connection between the artery and the vein, but the ball is in the brain, unlike a fistula where it's in the dura. So generally speaking, we think about these as an incidence of 1 in 100,000. Generally speaking, we think of the hemorrhage rate as 2 to 4% per year, but that's extremely variable. It actually is anywhere from about 0.5% all the way to 40% per year. Still, the optimal treatment of this is being worked out, but same as a fistula, we have microsurgery, focused radiation, transarterial, transvenous approaches. And so this patient was best treated with surgery. This is a very straightforward, easy surgical approach, and this was removed. We have the Aruba trial, which was meant to answer, which patients with these AVMs should be treated. We don't have time to really go through this in depth, but the Aruba trial was not all AVMs. It was patients that were deemed high risk for surgery, low risk for hemorrhage, or both. So in other words, poor treatment cases. So it's not all AVMs. At that point, when I was at Columbia, when this started, I think 1% of AVMs that were treated were going into the Aruba trial. And that's because we didn't, for certain AVMs, we thought we knew what the best treatment was, or for certain AVMs, we thought they definitely shouldn't be treated. And so it was really mostly like grade 3, grade 4 AVMs that were going into the trial that, again, were poor risk for treatment or low risk for bleed, or maybe a combination of the both. And that's why this trial was stopped, because it took so long to enroll these patients. You can see there were 100 sites enrolling patients, and we were only enrolling a couple patients a year. So you can see here, I think it was this is 5 years later, we've enrolled 40 patients. So this is a good example of a problem case. This is a massive AVM. It's in the motor strip. I would argue this patient shouldn't have even gone into Aruba, because treatment is associated with a terrible outcome in this patient. This patient was put into Aruba. They were randomized, thankfully, at the time, to no treatment. The trial was published, the early results showing, which we'll go through. But so this patient was counted as a success because at the time, when the trial was stopped, the patient had not bled, but this was only with 4 years of follow-up. Then this patient was interestingly randomized in New York by Moore, one of the originators of the trial. And I always think about the gifts, that he's given us. But this trial was very important in paving the way for what we need to do next. But so then this patient actually presented in Miami with this massive bleed. So even though they were counted as a positive in the trial, they actually had a negative outcome if you were to extend the long-term outcomes, which are still being accrued. This patient actually required a decompressive craniectomy, but still died, despite the fact, all we did is go in and remove the bone here to try and give them more room, and this patient still passed away. So in the Aruba, 223 patients enrolled. Again, this was stopped early. The composite outcome you can see here for stroke causing some deficit or major disability and death was 10% in the medical arm versus 30% in the surgical or in the treatment arm. This is based on randomization assignment. This is based on treatment received. You can see here is about 8% versus 35%. But there's a lot of problems with this trial and reasons that it was stopped. And it's important to understand that, so then we can use this trial to decide how we treat the next order of patients. So we're not going to go through all this, but selection bias, treatment bias, proficiency bias, outcome bias, follow-up bias. One of the issues is not all of these AVM patients have the same risk of bleeding. This was a great study by staff and Moore, which led to Aruba, which showed that AVMs have a really variable risk of bleeding, anywhere from 0.9% to 34% per year. That's astronomical. These patients down here in the 0.9% per year, certainly if it's an eloquent or a high risk AVM, we should be leaving those alone. These patients with a 34% risk of bleeding, if it's a low grade AVM, for sure, it should be removed or treated. So risk of bleeding, again, it's really variable. This AVM with outflow stenosis of the vein, and I think there were like 12 aneurysms, is very high for having a bleed, and this probably should be treated. And this patient was not initially treated, but later presented with a bleed, and then we treated. You can see here we embolized a number of these aneurysms, the deep ones and the deep feeders, and then we took this AVM out. Other AVM patients, this is a patient with intractable seizures. They're on 3 anti-epileptic medications, still with daily seizures, with really no reasonable quality of life. And, this is a tough case. This is left-sided, predominantly frontal. It's technically a grade 5 AVM because it was 7 centimeters. Grade 4 AVM. It's 7 centimeters, deep venous drainage, but it's just in front of the speech areas. I would consider this a very high-risk surgery, but the patient and family said, look, I just don't want to keep living like this. So either take this out or, I'm gonna find a bridge to jump off. Or fix this, or I'm going to find a bridge to jump off. For this patient, we went on to embolize the deep branches and take this out. And this patient is now on 1 anti-epileptic and has not had seizures in years. So for this patient, I think it is a reasonable option to take that heavy upfront risk, but it's really based on what is the patient's and the disease characteristics. Someone like this, I would meet with the family probably 3, 4, 5 times before taking on a really risky surgery like that. Going back to the trial, the question is appropriate treatment options. This patient was embolized 20 times before they had another bleed, and then they were transferred to us at an institution where we would regularly take this out. So for grade 1 and 2 AVMs, I think we know that the best treatment option is surgery. We can achieve that with almost a 1% risk. And we've done, this is Roberto Giro's initial publication. Then we published one when I was at Jefferson. The problem is in Aruba, only 66 patients received a single treatment. And that's because a lot of these centers didn't do a lot of surgery. And on top of that, most of them received either embolization or radiosurgery. Only 7% of these patients in the trial received microsurgery. So this was really a trial of no treatment versus multimodality embolization and radiosurgery, which we know has high risks. And we've now, published many papers on these different therapeutic options to work out what's best for which patient. This is a patient with an AVM right in the motor strip. Unruptured, I'm usually leaving this alone. Depending on certain features, especially if they're high risk of bleeding, I would do focused radiation. And this was a study that we published when I was in residency, looking at over 1,000 AVMs. And then this study was over 2,000 AVMs. This was with greater than 8 years follow-up, showing good outcomes for Gamma Knife. And it's really, this is a great case for Gamma Knife, a smaller AVM right in the motor strip. So outcome bias, we'll skip this, but this was a 12-year-old presented with significant headaches, vision alterations, doing well in school, but now having almost bi-weekly visits to the ER because every time she has one of these severe headaches that they are not able to control with migraine medications, she goes to the ER. She goes to an outside hospital, found out this massive AVM. They put a drop of embolic material in here that does nothing. You can see her, she's got a number of AVMs, deep venous drainage. After over like 20-something visits to the ER and many discussions and meetings with the family, we ultimately decided to treat this. We know up front, I told the family up front, look, if we're going to treat this, I'm going to make her homonymous hemianopsia worse. It's probably not going to get better over time. But these kids, if you're a kid, you're going to adapt well. And generally speaking, down the road, young kids don't notice this homonymous hemianopsia down the road. They go on to be able to read very well. So post-operatively, she had expecting worsening of her homonymous hemianopsia. In the Aruba trial, this would have been counted as a negative outcome. But this patient down the road now has no homonymous. She's gone on to make a complete recovery. She's the ambassador for TAF, which is the Global Aneurysm AVM Foundation. And I would say this is a positive outcome, even though in the Aruba trial, this would have been counted as a negative outcome. Other issues, this study was projected to have over 20 years of follow-up, and they stopped it at 5 years. And that's all that we have in terms of what our outcomes are based on. On average, the mean follow-up in the trial was only 3 years. They didn't confirm obliteration in a lot of these patients. So again, I think of this as a negative trial, a little bit like those 5 negative mechanical thrombectomy trials. We know that treatment is beneficial for select AVM patients. The Aruba trial gives us further information that should guide us in terms of which AVM should be treated. And again, once the Aruba trial came out, this is another great paper by Evan Luther and the rest of the team. We found that there was a reduction in treatment of AVMs based on Aruba. And it's not, that's in some ways because primary care doctors stopped sending us AVMs because they saw this publication in the New England Journal of Medicine. So again, I think it's not that all these patients need to be treated, but we need to balance it. And it's patients that are high risk of bleeding, low risk of treatment, that are optimal for treatment. And then it's a matter of which of the treatment options is best. So we'll try and blast through the last couple of cases. We're getting towards the end. 20-year-old presents with headache and weakness, has this large bleed. You see here abnormal vessels. This is confirmed as Moyamoya disease on an angiogram, which means a puff of smoke. They have progressive arteriopathy and loss of the carotid artery in the supraclinoid segment, and then progressive changes throughout the brain. Moyamoya phenomena is well-defined in Eastern population, more common in Asian. It's fairly rare, and it has this bimodal presentation, with kids presenting more likely with ischemic presentation, adults more likely with hemorrhage. In the United States, this is actually not true. Most of the patients will, whether they're kids or adults, more commonly present with ischemic symptoms. And we're still working out, what's the optimal treatment for this patient. We usually do direct bypass at our institution, but the optimal treatment and which treatment is still being worked out. This is a bypass double barrel. You can see here it's filling down all the way to the MCA segment. And you see here this double barrel bypass filling down to the MCA segment. But we still don't know what the optimal treatment is. This was a study still when I was a resident, direct versus indirect bypass. These are studies that we were working on, looking at neurocognitive outcomes for these patients. What's the clinical features? Really, are there different genetics and different presentations in the United States? There's so much that still needs to be done here that could be taken on by, residents and other faculty members. So these are things that we're still working on. So last case, we'll try and blast through aneurysms on the last one. This is a 23-year-old medical student presents with severe headache while studying. She collapses. She has this subarachnoid hemorrhage. She actually presented in the Caribbean, took 3 days to get here. We put in an EVD. She has early DWI changes and this aneurysm. And, the question is really, at this point, she was grade 5, comatose with DWI changes. She had troponin leak with myocardial stunning, and she went into a pulmonary failure with ARDS in a delayed fashion. But when she first presented, she's got DWI changes. She's comatose. She's Hun-Hess grade 5. This is a patient in New Zealand with this aneurysm that would be extubated in the emergency department. I would argue we need to consider aggressive management for all of these patients and then consider withdrawing care if they don't improve. The question is, why do these patients get so much damage? This is a picture of an aneurysm forming in the lenticular striates, and you can see here, this is, high flow in the vessels that causes this aneurysm to form through this vessel weakness. We'll fast forward, this, maybe skip this. This then leads to rupture of this aneurysm in some patients. So unruptured aneurysms, 1 to 9% of the population. Smoking, other characteristics may lead to increased risk of bleeding. And the question is, again, which of these patients should we be treating? I think we're going to skip this, but it's generally speaking patients that are high risk of bleeding, low risk for treatment. We talk about these trials for aneurysm patients and the natural course of these patients. This is a 1 millimeter aneurysm that ruptured. So still, we don't know about which patients, completely should be treated. In the unruptured international, the UCAS Japanese study, what we found was 7,000 patients entered the trial. They were deemed high risk for treatment or low risk of bleeding. But the problem is more than half of the patients went on to receive treatment during the trial. So the publication of the trial has a huge selection bias, and it's based on just the patients that did not receive treatment. So that's half the patients. So we're still working out, which patients should be treated. We know that these patients can present with a variety of presentations. I'll try and wrap up because I know we're getting towards the end, but they can present with subarachnoid hemorrhage, intracerebral hemorrhage, subdural, intraventricular hemorrhages. They can present with giant aneurysms with mass effects. So we still don't know, what's the best treatment based on the optimal patient. Someone like this got a bypass and removal of this aneurysm when I was in training. These patient with mass effect and third nerve palsy. So, when I was training, it was, do we clip, do we coil? Now we're way beyond that. It's based on patient and disease characteristics. What's the optimal approach? We've stopped arguing clip versus coil. It's which one is better for which patient. So this was a patient that we did many years ago. They got a radial artery graft, and then we clipped this aneurysm. But if my brain looked like this, I'd be really disappointed. When I trained someone like this, Cassell would do a massive craniotomy. And so we moved towards minimally invasive approaches for unruptured aneurysms. So this patient, 3 aneurysms, this patient went on to receive surgery. Maybe we'll skip this just due to timing. But we moved to doing these minimally invasive approaches. So this is a mini terional. You can see here a 2-inch incision, almost a 1-inch craniotomy. We can clip all 3 aneurysms in this approach. You can see here the craniotomy. This patient goes home with a Band-Aid. This is the patient afterwards. We've now moved towards other approaches as well. This is the superior lateral orbitotomy approach, which we're now using for a lot of these aneurysms, especially ACOMs. You can see the superior lateral orbital approach. When you open, you can't even see the sylvian fissure. But this approach is still great. Once you drain some CSF, you can get down, split the fissure, and do these in minimally invasive approaches. This was another patient, famous model. We did an eyebrow approach for a patient that was coiled repeatedly. You can see the coil mass, aneurysm keeps coming back. Eyebrow, 1-inch OZ craniotomy, and we go down, we clip this aneurysm, and she has a great outcome. Maybe we'll skip this. When we can do endovascular approaches and achieve a similar outcome in terms of efficacy, durability, and safety, of course, I'm gonna prefer endovascular, and that's because we can achieve a minimally invasive, much better approach. So for someone like this massive ruptured ophthalmic aneurysm, I'm going to coil this. We've got a number of studies going with larger coil masses and larger coils. We've been contributing to these different trials. This was the SMART study, the WAVE study. We were one of the highest enrollers in both of this. This is the ongoing Sterling study, which pays per patient. That goes back to support our research. And we're looking at different types of coils. We now have improved microcatheters. We've done research on that. Improved balloons for balloon-assisted coiling, improved stents. We have some study for stents, for stent-assisted coiling. And then for these wide-based aneurysms, improved approaches as well. So this may be Y stent coiling versus single stent coiling. Flow diverting, we've got a lot of new flow diverters. We have new flow diverting trials. We'll skip this maybe. So it's now, really what's the optimal approach based on different treatments. These are all flow diverting publications that we've originated or contributed to. We're now working on different surface modifications for flow diverting stents. And we did the animal work for this, doing over 150 rabbit aneurysms for this study. We're now on to different flow diverters. We contribute to the SURPASS study. This is compassionate use for a Silk Vista baby that we did. We're looking at different constructs for coiling aneurysms. We contributed to this Pulse Rider study. The Citadel, this was another patient that we just enrolled, a new coil device. And so we're really moving way beyond this. We've got so many new devices The problem of that is we're seeing new complications that we couldn't have even imagined before. This is patient coiled 7 times with a stent in place, progressive edema, refractory seizures. This is another patient treated in another hospital with a flow diverting stent that they couldn't detach. They had to cut this at the leg. These are flow diverting cases that presented with distal delayed hemorrhages. And so we've had to go in. This is, unfortunately, I've even done cases where we've removed pipeline. This is intraoperative pipeline, cases where we've had to do bypasses for cases where they injured the vessel. This was a case they coiled many times, presents with another hemorrhage. Both femoral arteries are occluded. This is a radial approach. You can see here blowout, coil mass with a fetal PCOM. We went in, removed this coils, and went on to treat this. So our original case, this medical student, we went on to clip. She was comatose for a while, had every complication possible, vasospasm. Ultimately, though, started waking up around day 7. Family wanted to progress with all goals of care, went on to rehab, made a remarkable recovery from grade 5. This is her finishing her master's degree. She just published her first publication on recruitment of aneurysm patients. And so I think now we're in a really tough situation. This is my Monday clinic, and these are patients that are treated many, many times. The question is, what do we do with these patients? New technology is making this easier, and that's what we're working on in the laboratory. I'm going to skip this, looking at basic science and how basic science can improve medical therapy, imaging, and treatment options. I'm going to skip this, I guess. Looking at new imaging, new treatment options, new stent surfaces. We did one of the first cases. This is a compassionate use for the stent surface modification, new stent coatings. And, so this is moving us forward to our funding new trials. And again, if these future trials are, how can we come up with medical therapies, better imaging options, better treatment options to treat these patients? So in conclusion, I think it's 9 o'clock. Multimodality assessment is necessary for all complex vascular cases. These technologies continue to provide minimally invasive treatment options. Research will need to keep up with these improvements and to carefully assess novel complications and outcomes. But now more than ever, further trials is necessary to better define the optimal treatment based on patient and disease characteristics. It's not clip versus coil, it's what treatment based on what characteristics for which patient. So thanks very much. Support our lab here, all our non-SaaS hashtags. I always like to give thanks to my son whenever I take time away from spending with him to do talks and things like that. So thanks so much to the faculty and everybody listening to me ramble for a bit.
That's great, Bobby. Amazing, amazing work. I was just going to ask you one quick question. That case you presented of the late hemorrhage that was in the Aruba trial. I'm not a big fan of case reports, but that would be a good case report, just showing how following your patients can actually result in a bad outcome. And I wondered if they might ding you for operating on it and having the patient die, and they would say, oh, this is a failed surgery.
Absolutely. And, I guess it's like 20 slides back, but Aruba looked at, it was based on treatment randomized, but they did look at what outcomes based on what patients received, because so many of the patients were randomized to observation and then later said, no, I want to have this treated because they had progressive issues. And that's exactly right. This is the problem with Aruba. This was counted as a positive outcome. In the follow-up for the study, they'll analyze it based on patient treatment received and treatment randomized. But no matter what, that patient's going to have a bad outcome. And they had surgery, even though we didn't remove the ABM. So we wrote a number of editorials on the problems with Aruba. And that's why we continue to, publish. Luther did a great job with that national inpatient sample study. You're right. This patient died, and we should now do a follow-up, because we're using the primary data from Aruba. I didn't talk about that, but we have a number of publications where we use the primary data from Aruba to look at risk stratification. So the team has a number of other papers where we've used that data to publish other important risk stratification papers. So we're overdue for follow-up, and maybe this is the time to, address another editorial, use this case as a case report or a response to say, we need to have continued follow-up. But I agree, You know, even when we look at the as you know, the cases for the oral boards, a lot of these patients only have 3-month outcomes. And it's not till years later that we realize that spine surgery we did was a bad idea, or that AVM treatment was a bad idea, or it was a good idea. So great point, and thanks so much. Any other questions? I know we're sort of at time or just over.
Bobby, that was great. That was a tour de force. Really nicely done. Great summary of our specialty in the landscape of trials. So really enjoyed that. Great job.
Yeah. Thank you so much. And you know, it's so awesome to have you here. Awesome to I think Adib's now been added to all our protocols, or we're working on adding him. So we're excited to you know, he has a lot of studies that he's interested in spearheading and launching, which I'm excited to contribute to. And I think he'll be a great collaborator to help with us in enrolling patients for a lot of these studies as well. So, you know, excited to have you aboard and join the team, and excited to enroll in some of the studies that you're going to lead up.
Likewise. Thanks, Bobby.
I guess the last thing, I think most of the people have chimed off, but for residents, you know, come by and talk to me. We have research teams to help start a lot of these studies. One of the trials was published in the New England Journal, was started by a resident, and they were the first author. That was the Stitch trial. So you can start major trials as a resident that have a major impact on our treatment. So thanks so much. I know we got to get on to cases today, so appreciate everybody hanging in there.